YouTube as well. All right, so dysrhythmias. Let's talk about abnormal rhythms. I am going to split these up for you. Hang on, come on. Let's go. There we go. I'm going to split them up into 4 different categories because the treatment, so if you're going to make a, and you will see I make a table off of each one: bradycardias, atrial rhythms, ventricle rhythms, and pulseless rhythms. We're going to make a table of how to recognize them, how to monitor them, how to treat them, and how to teach about them. And we're going to make a table for each one of these. So not for each rhythm, but for each section. So there's going to be 4 tables, basically. There's going to be all the Brady's, they're all treated the same. All the atrials, they're all treated the same. All the ventricles, they're treated the same. And all the pulseless ones are treated the same. So, oh, no, I don't want to stop recording. I just want to remove the screen. I want to be able to see my chat. Okay. So, we're going to walk through each kind of arrhythmias. I'm going to tell you off the top of the beat. I'm going to teach you blocks, but I am not going to put blocks on your exam. So if you are struggling with them, that is okay. It takes tele nurses and ICU nurses quite a while, and it is the most missed questions even for ICU nurses and telemetry nurses. So I'm not going to test you or expect you to be proficient on blocks, but I am, or AV blocks or bradycardia blocks, but I am going to show them to you. And what we're going to do is when we're done with this lecture, we're going to go through the ACLS pretest, which is where they give you a bunch of rhythms and you identify them. So we're going to go through that together and show you some rhythms in real time and go through that. So we're going to go through these 4 sections, show you the most common rhythms in the Brady's, most common rhythms in the atrials, most common rhythms in the ventricular dysrhythmias, and the most common pulseless. And then we're going to show you the treatments for each of those 4. So let's jump in. Bradycardias. We put the blocks in bradycardias, even though blocks can have a normal rate, because if blocks are going to get worse, they're going to get bradycardic. But not every heart block is less than a rate of 60. Heart blocks are normal until they're not. So we're going to put the blocks in the bradycardias because we treat them all the same. So the most common bradycardias include the heart blocks. So let's go in and look at them all. So a bradycardia, so we're going to have those 5 things that we look at. Remember, I told you the QT we only really look at when we're worried about meds that are prolonging QT interval. We're really not going to look at them right now. We're going to have those 5 things that we're looking at. We're always going to be doing the rate. We're going to be doing P waves before QRSs. We're going to see if the QRS is narrow, whether it's regular, and whether our PR width is okay. I will tell you the summary for all the Brady's, is there something wrong with the PR interval? To put it into the atrial category, there's something wrong with the actual P wave. So in bradycardias, you have a P wave. There's just something wrong with the PR interval. With atrials, you have something wrong with your P wave, but you have a normal QRS. With ventriculars, you have no P wave and a wide QRS, and pulseless, you don't have a pulse. So really, you can categorize them very easily by looking at the P wave first, and then we kind of go into looking at the QRS. So all the Brady's are going to have a P wave. They're just going to have something weird with their PR interval. So we have that, right? All the Brady's have a P wave. I'm going to tell you that, to be considered a bradycardia, a treatable bradycardia, you have a rate less than 60. But not every block is a treatable bradycardia yet. Some blocks we just monitor. Let's look at the rate on this one. I'm going to tell you that every strip I give you is a 6-second strip, so you can do we can count, there's 4 QRSs there. 4 times 10 is 40. This rate right now is 40. So we can just write that rate of 40. Qualifies for the bradycardia by being, what happened there? Why did it do that? Hang on 1 second. I don't want that. When I go to drawing, it disappeared. He's back. Let me share a different way. Hang on one second. Let me fix that so that when I go to drawing, you don't lose the screen. One moment, please. I'm going to share my screen. All right. Now is that working? Let me share this appropriately. Hang on one second. All right. So now we know that its rate is 40. Do we have a P wave before every QRS? Well, there's one, there's one, there's one, there's one. Yes, we do. Is our QRS narrow? It is 1, 2, 3 small boxes. That's correct, because it is about 1 small box right there, maybe 2, but it is between 1 to 3, so we are good with that. Let me just make sure my chat went away. Hang on one second. Let me put my chat back so I can see you guys. And then is it regular, R to R? What you'll do on that one is if it looks regular, it probably is regular. We'll show you irregular. Go away. I'm looking at my picture instead of what you guys, there's this chat. Okay. And then our PR width is supposed to be 3 to 5 small boxes. So we are going to measure from the beginning of the P, to the QRS. So the QR interval, so the top of that QRS. So right here we can see we are at 1, 2, 3, 4, 5. We're getting to be a little longer than 5 small boxes. So it's getting long, but it's still normal. So we're going to just leave this where it is, but the rate is less than 40. So we're going to call it sinus. Sinus, if you have a sinus tachycardia, a sinus bradycardia, it means everything is normal except for the rate. So we're going to leave this one alone because we're right at that 5 block mark. It's still normal. We're calling this a sinus bradycardia. Let's look at some other kinds here. Let's move on. Come on, let's move on. Trying to get my computer to move on. All right, the heart blocks. Again, if you do not get this right away, do not stress. They won't be on the test, but I am going to show them to you. I love this poem. It has helped me for many years through ACLS tests. If the R is far from P, you have a first degree. Longer than you drop, then you have a winky Bach. Some P's don't get through, you have a Mobitz 2. So I love the rhymes, love it. But let's take a look at each one. First degree AV block, the problem is only with your PR. You do have a P. So if we look at the rate, this rate is actually, what do we got going on here? Let me get my drawing going. We have 1, 2, 3, 4, 5, 6, 7. So it doesn't qualify for a bradycardia right now because my rate is 70. So the rate can be variable on this one. And this is why I'm not going to really, I mean, if you're going to get a block, did I freeze on you? It looks like I froze. Okay, well, I don't know. The picture that I'm seeing on my screen looks frozen. So anyway, this rate is normal. But what we are looking at is, we could call this normal sinus rhythm, except for the fact that it is, let's look at that PR interval. Let's dig down here, and I'm going to put a mark here to here. So we are basically looking at how many small blocks we've got. We've got at least 5, 6, 7, 8. We've got 8 small boxes. That is a huge, that's much bigger than 3 to 5 small boxes. So that is a long PR interval. We do have a P before every QRS. There's the P. Oh, sorry, that's a T. X that out. P, 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 P. And this is where blocks are hard because you don't know which one's a Q, which one's a T unless it's perfect. You know, you're assuming that looks good. P before every QRS, yes, our QRS is narrow. It is 1 to 3 small boxes, so we're going with that. It is regular, which is where we check from the R to R and spacing that out. It is regular, but our PR width is the only thing that is off. Then we call that a first degree block. We will talk about how to treat each one because all the Brady's are treated exactly the same. Let me see if I can get rid of this thing. Go away. Picture. Here is a second degree. So there are 2 second degree tops. Take a breath. 2 second degree blocks. There's a type 1 and a type 2. Second degree blocks are where the PR interval gets longer and longer and longer until it drops a QRS. So when we look at this one, first of all, we're going to look, do we have, let's look at our rate. First of all, we got to always look at the rate first. 1, 2, 3, I wasn't trying. 1, 2, 3, 4, 5, 6. So our rate is 60 here. So right now we're like, okay, that's starting to get to be a bradycardic one. Let's look at the PR interval. Is there a P before every QRS? There's a P, there's a P, there's a P. Something's missing here. I'm not really sure what's going on here. We're going to put a big question mark there. There's a P. And that's technically a P before every QRS, so we're going to leave it the way it is. We're like, do these go together? We're not really sure. But there's a P, there's a P. So we're going to say, yeah, there's a P before every QRS. But that one's really, really long. There's something weird going on there. So let's go back and look at that. But first we're going to look at QRS narrow. It's 1 to 3 small boxes, so yes, it works. Is the R to R different? Is the R to R distance the same? It's the same there. And now it's really long, and then it goes back to being short again. So we are irregular now. This is not right. There's something wrong. We need to investigate a little further. When we look at the PR width, we find the problem. So here we see we have P. We're going to start it there. PR of about 5 boxes. Then we're going to go here, a PR. We're a little bit longer now. We're like at 6 boxes. Here we've got a PR going that's almost 2 large boxes. And now we have a PR that's really, really, really long. And then we go back to a normal PR, a little bit longer, and then you will see this pattern throughout multiple, and sometimes with blocks you need to look for longer than 6 seconds to see. But basically your PR starts normal and then gets longer and longer and longer, and actually the QRS looks like it kind of drops out. So that's a second degree type 1. It's also called a winky Bach. This one is a second degree type 2. A little bit more serious. This one really does have a dropped out beat. It's not longer and longer. What you see here is your rate. We're going to call this one a rate of 40, so we definitely have to name this one. Let me go back. This one's got a rate of 40. And is there a P before every QRS? 1, 2, 3. Oh, I think something's missing here. Yes. So there's something wrong here. So we're probably at that second degree. Because remember, first degree isn't going to have anything missing or anything wrong with it. A first degree is just going to have a long PR interval. This QRS is narrow, normal. It's 1 to 3 small boxes. So yes, we're good there. Is it regular? We've got regular, regular, and then this is really long. So we are now no longer regular, we're irregular again. Something's missing here. This is a irregular beat. So we can't call it a first degree. Something's messed up. We do have visible P waves, but we have to look at that PR interval. So we start looking. We have, this is pretty long here. That one's about 5 to 6 small boxes here. Then we've got this one. We're actually going to measure, let me count these. We have 1, 2, 3, 4, 5. I have this blown up on my screen. I'm not magical. We have 5 there. This one is 1, 2, 3, 4, 5. We're 5 there. This one is 1, 2, 3, 4, 5, 6, maybe about 6. This one, we're not really sure. But what this is this could either be first degree type 2, depending on how you're reading it. I think I was reading this one. This one I was reading just till the Q, not to the RS. So let me go back and read this appropriately. I'm not marking these appropriately. And we use this, we actually use calipers on the computer. We have these fun little devices that will mark this for us. So basically we're going here. Let's see, 1, 2, 3, 4, 5. We're going to stick with 5 there. This one to here. 1, 2, 3, 4, 5. So I think we're sticking with 5 on this one. This one starts here, goes here. 1, 2, 3, 4, 5. So close enough. This one's about the same. All those PRs are the same, and then we have something getting messed up here. The difference is that this one doesn't get longer and longer and longer before you have your messed up beat. You are exactly the same before you have your messed up beat. So this one is just dropping out of nowhere, and that one is a more concerning block than something that is either long consistently or longer and longer and longer than you drop. The third degree is really, really hard. This one doesn't really match our criteria. Something's wrong. Let's go through our criteria. A P before every QRS. So let's check that. Yep, there it is. Yep, there it is. Yep, there it is. Yep, there it is. I'm getting P's before every QRS. Check, check, check. Okay. Is our QRS narrow and normal? This one's a little bit bigger. This one's kind of starting here and going all the way to here. But it's still 2.5, 3 boxes. It's still narrow. It's a little wider than our other ones there, but it's still considered normal because it's 1 to 3 small boxes. Is it regular? We don't have any dropped beats, and if we marched these out, yes, it would be regular. These distances are all the same, so it is regular. So now we're going to go to our test, our PR width. Remember, we're either consistently elongated for first degree block. For second degree, we're longer, longer, longer than you drop, or we are same, 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 and then we drop. We never have a dropped beat here. So let's look at our PR interval and see if we can get it. So we look at this one. Let me clear this out. And we're going to, and this is why we're not testing you, because there's a lot of reading going on here. This is 5, 6, 7. This is 7 small boxes. Let's look at this one. This is about 3 small boxes. Let's look at this PR interval. This one is, let's see, that one's about 7. This one goes to 1, 2, 3, 4, 5, 6. This one's about 6. What we're seeing here is that there's no system to this. This one's about 3 or 4. So we don't have a consistent PR interval. We don't have a prolonging PR interval. We've got PR intervals that are all over the place. Our PR width doesn't match any criteria. We have no consistently long PR interval. If they were all 7, we would have first degree block. If it was 3, then 4, then 5, then 6, and then a drop, it would be second degree type 1. If we just had 3, 3, 3, and then a drop, we would be second degree type 2. Here it doesn't match any pattern. So we have to do an additional test and see if they're just not communicating, which is actually what happens here. So if we took out all the P's at all, let's take out everything that we think is a P. These match. This is regular. So we're regular there. Then we're saying, let's clear out, erase everything. Let's clear out the QRSs. And then we start looking at our P to P intervals. Look at this. Our P to Ps, they are exactly the same. So what is happening here is our atrial conduction, the P waves, are just P, 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 and the ventricle's doing its own thing, QRS, 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 but they're not communicating. Yes, there's a P before every QRS, but there's no pattern to the PR width. Does that make sense to anybody? It's very hard to see, and this is why I don't test you on it. But I wanted to give you a little bit of a background, and I will do some examples when we do the ACLS pretest. So first degree is just a long PR interval. All of them are greater than 5 boxes, 5 small boxes, all of them, and they're equal. First degree or second degree type 1 is your PRs get longer and longer and longer. So let's go back and look at all of them. We can see, I'm going the wrong way. Their first degree, just the PR intervals, they're the same, they're just really long, longer than 5. The second degree type 1, the PR intervals get longer and longer and longer until you have a missing QRS. The second degree type 2, the PR intervals don't change, they're consistent until you have a dropped QRS. And the third degree, which is the hardest one to see because it looks like it matches everything. If you don't do the PR interval test, you'll miss this block because it looks normal. The rate is 1, 2, 3, 4, 5, 6, 7, 80. The rate is 80. The QRS is narrow. It's regular. You're thinking, hey, that's pretty normal. There's a P before every QRS. I've got a normal sinus rhythm. But that fifth test, the PR width test, messes you up because the PR width is short and then long and then long and then short and then long. It doesn't follow any pattern the way it's supposed to. And there's no dropped QRSs. And that's what makes it third degree. So take that with what you will. Like I said, it's very confusing. I get that. I won't test you on it. Let's talk about, we have a Brady now. Whether it's a block or a sinus bradycardia, anytime you have a heart rate less than 60, it counts as a Brady. I put the Brady's in there because after a while, Brady's will drop. Blocks do drop down to bradycardia, so we treat blocks the way we would treat bradycardias. All of the rhythms, and you will see this slide repeated, all of the rhythms, we go on a flow chart. If they are asymptomatic or symptomatic, it determines how we treat them. The first cue is either an abnormal EKG, because you're watching it, or your patient complaining of palpitations or an irregular pulse. If you're not monitoring the heart, the only way you'll see that you're having arrhythmia is an irregular pulse or a slow pulse. Your key assessments right away that you need to do when you either have an abnormal EKG of any kind or a patient complaining of palpitations or having an irregular or slow or rapid pulse is you need to do a blood pressure. I say heart rate on there because we need to get a rate, but if you're watching it, we've already done a heart rate. But you need to get a blood pressure, a pulse ox, and ask the patient whether they're short of breath, dizzy, or ready to faint. Okay? Every single arrhythmia, I don't care what it is. Get a blood pressure, get a pulse ox, and ask them if they're short of breath or dizzy, because that will determine whether you're asymptomatic or symptomatic. If your patient's like, oh, I have palpitations, but your blood pressure is okay, your pulse ox is normal, then we are asymptomatic and we will do something not as dramatic. Maybe just monitor it. You might have an arrhythmia right now sitting at home. If you check your pulse and it's irregular, but your blood pressure and your pulse ox are okay, then we're not going to do anything. So if your blood pressure is stable, no shortness of breath, your pulse ox is okay, and you're not dizzy or feeling faint, then you are okay. I don't care if your heart rate is 20. And that's something that cardiac nurses are famous for. I'll have someone come careening down the hall and skid in front of my room and say, your heart rate's 40. And I'm like, I don't care. It's fine. He's sleeping. His blood pressure's okay. His pulse ox is okay. I don't mind. Let it be. We have athletes that live with a resting heart rate in the 40s, 50s. That's okay. They're asymptomatic. We don't just go barreling into a room and treating rhythms on the monitor. You have to look at your patient first. So you will always be getting a blood pressure, a pulse ox, and asking your patient if they're short of breath or dizzy. And if they are not, they're asymptomatic. So I need that slide ingrained in your head. One of your first steps is going to be evaluating your patient. Now, if I've already on a test question evaluated the patient for you and told you that their blood pressure is low and their pulse ox is 88, I've already evaluated the patient. It's been done. You're supposed to tell whether they're asymptomatic or symptomatic. So the first thing we're going to do when we have an abnormal EKG is you're not going to go skidding into the room with the code cart and doing things to them. You need to go and assess your patient. Your patient may be perfectly fine. If you're symptomatic, any one of these gets you classified as symptomatic. Decrease in blood pressure, dizziness, feeling faint, having any kind of chest pain, having shortness of breath, or a low pulse ox, or sweaty. Any of those mean we're not perfusing okay, this rhythm needs to be treated. Does that make sense? Please check your patient. We're not treating rhythms, we're treating patients. So we're going to go look at our patient. Of course, those are our key assessments to monitor your EKG, your oxygenation, your perfusion. If you are asymptomatic, they'll probably just go straight on to testing. If you are symptomatic, we're going to do something about them. So if you're asymptomatic, and any asymptomatic patient, you're now up on our list, man. You got an abnormal rhythm. We're going to watch you. If your heart rate is 40, I'm going to still watch you a little closer than if your heart rate is 68. We're going to make sure that you are not stressing out the heart in any way, shape, or form. Keep calm, keep quiet, rest periods, maybe fall risk precautions. If your heart rate's living in the 40s, you might be worried that they could become asymptomatic or symptomatic at any moment, so you're going to treat them a little more delicately. Continue to monitor your EKG, oxygen, and perfusion. If this is a new rhythm, so if they were never bradycardic in their entire lives and this is a new rhythm, you need to notify the provider. They'll probably order cardiac testing, cardiac consult, and electrolytes. If they are worsening, so you have a bradycardia, you have a heart rate of, let's say, 48. No matter what the rhythm, whether it's a sinus or a block, you have a heart rate of 48. You need to go check your patient. If your patient wakes up and their heart rate jumps up, then they were just sleeping. It's fine. They're asymptomatic. Their heart rate's 48. You go in and talk to your patient, and they say, I'm not dizzy. I don't know. What are you talking about? I'm feeling fine. Blood pressure's stable. Then you will just call the physician. You will keep them on an EKG monitor. You will keep them on an oxygenation. You will call the doc and say, hey, I have a new bradycardia. They're fine, but I have a new bradycardia. They will probably want to do some testing and electrolytes and figure out what's going on. Let's say that you went into your patient with a rate of 48, and you're like, how you feeling? And they're like, ugh, I'm not feeling that good, actually. I'm a little nauseous. I'm a little dizzy. Now you have a symptomatic patient. Or you walk in and you have, you draw their blood, you get their blood pressure, and it's 90/40, and their normal blood pressure is 120/80. Now you have a symptomatic patient. So on these symptomatic patients, give them oxygen. If you are symptomatic, meaning you're short of breath, or you have a pulse ox low, any arrhythmia that is symptomatic gets oxygen. Okay? You can have an oxygen sat of 96, but if they have an arrhythmia and they are symptomatic, they will get oxygen. Now, your asymptomatic patients that aren't dizzy, have a normal blood pressure, have normal perfusion, they don't need oxygen. You're just going to keep an eye on that rhythm. But if they are symptomatic in any way, shape, or form, they are dizzy, they are syncopal, they're having chest pain, they have a low pulse ox, or they're short of breath, any symptom, if they fall into the symptomatic category, go ahead and put some oxygen on. Oxygen doesn't hurt a heart. They will allow you to put oxygen on any kind of arrhythmia, especially if it's symptomatic. So go ahead and put them on oxygen. And then the two medicines for bradycardia, and for every kind of rhythm we have, we have meds, and we have some kind of electricity. We don't get to play with electricity until we've tried medications. I know as much as fun as electricity is, you do medicine before Edison, and Edison is electricity. So always we'll try a couple of medicines before we go and start pounding electricity at your patient. But every single arrhythmia does have an electricity treatment as well. But the medications for it are atropine and dopamine. Atropine and dopamine will get a heart going a little bit faster, get your heart rate up. If you cannot get your heart rate up with medications and you are symptomatic, then the Edison or the electricity is pacemaker. Any questions? Let me just pause for a moment on the treatment of bradycardias. Does everybody understand our little flow map that we have going on? Any questions? Nothing? Crickets? Crickets, crickets, crickets. I need a cricket noise. Okay. I'm not seeing any questions pop up. Let me just make sure I'm seeing the full chat. Oh, you know what? My chat wasn't updating. I'm sorry. There were people that were asking about the PR interval. To clarify the PR, let me go back to some of the questions then. Just to clarify, the PR interval is really the start of the P to the Q point. It's actually the start of the P to the top of the R. So let's go back and look at some of these. So sorry, I missed a couple of questions as you were going through. When we're reading a PR interval, and usually it's like half a box, so you're not missing that much. Let me draw my line here. So we're doing from the start of the P, so I'm going to draw that line straight up, to the R. This is Q, this is R, and this is S. Okay? So we are really reading the number of boxes between the beginning of the P to the top of the R. So that clarifies PR interval. Is there a Mobitz type 1? Yeah, that's second degree type 1. It's also called Winky-Bach. It's also called Mobitz type 1. So yeah, that's this right here. Let me go back. This is actually technically second degree AV. This is technically Mobitz type 1, but Winky-Bach goes well with our poem, but it is a Mobitz type 1, and this is the Mobitz type 2. And then there's a couple extra P waves in this one. I think you're probably talking about this one. Yes, there's a lot of extra P waves, and that's why we had an issue with that one. Is Brady more common than tachy? What's the difference between an extra P wave and a dropped QRS? The dropped QRS means that where you expect an R, there isn't one. So here we have an R to R interval of, let me go back. So this one does not have a dropped QRS. Let me show you what I mean. So we have an R to R interval of, let's guesstimate 1, 2, 3, of about 4 large boxes. A little less than 4 large boxes. We are getting that R to R interval with nothing dropping out. Okay, we're doing good here. There's an R to R interval completely regular. There's nothing dropped. Let me show you the dropped R to R. Here we're expecting, let me draw again, go back to this one. And this is kind of a short, the slower it is, the harder it is to read because you just don't have as much to look at. Here we have an R to R interval of, let's see, 1, 2, 3, almost 4 boxes is our R to R interval. So here we've got 3 with some extra. We're about the same. So if we had 1, 2, 3, we would be expecting an R right here. There's nothing here. That's the dropped beat. Does that make sense? So that's a dropped QRS, is that when the R to R doesn't march out, where what this is missing, that's a missing QRS. That should have been a QRS, and it's not there, so that's a dropped beat. Let me look at this one. So here, we're expecting, so we're going to look at a dropped beat here. You're expecting, we've got 1, 2, 3 little little more than 3. We've got 1, 2, 3. We're expecting 2, 3, a beat right here. It's dropped. So a dropped QRS is just where it should be regularly marching out. It's not there. And that's what a dropped QRS is. If you're not dropping one, like you're not here, this is just every single QRS is right there where it's supposed to be. There's no dropped QRS. Okay. So sorry about missing some of those questions. Why is Winky Bach worse than Mobitz type 2? It's not, actually. In degrees, these actually, luckily, go in order of severity. First degree, nobody gives two craps about, really, honestly. Nobody cares. A first degree interval is just like a first degree block. You may be like, oh my God, I have a first degree block. Nobody cares. It doesn't matter. Everything's working normally. It's just a little bit longer. Maybe you got some scar tissue around your atriums. Who knows? Nobody cares. Never progresses to really anything that bad. So first degree block, nobody cares. Second degree block, type 1. Okay, you might get our attention, but we don't really care that much because we know what's going on here. It's prolonging, you get a drop, but at least we get some warning. So we'll see some warning going. So first degree or second degree type 1, Winky Bach, not that big of a deal. Mobitz type 2 or second degree type 2 is a little more serious because there's no warning. There's no warning sign. All of a sudden, just a beat disappears out of nowhere. That one's a little more worrisome because that means that there's trouble with communication between the atrium and the ventricle. Here, the atrium and the ventricle are communicating. It's just that things are getting backed up. So that PR interval gets longer and longer and longer. And so we kind of expect to see the drop. So it's not that big of a deal. We'll keep an eye on it. But this one worries us because we're like, whoa, that PR interval didn't prolong. It's just like randomly dropping. That one's more worrisome. So they kind of go in degree of worrisomeness. And then third degree is very worrisome. The problem with this one is basically there's no communication between the AV. They also call this AV disassociation as a rhythm because the P waves are doing whatever they please. The QRS are doing whatever they please. They're not talking to each other. So the line of communication has been cut. And our heart rate is only what the ventricle is deciding to do for itself. The ventricle has to take over and make its own rate. And in third degree heart block, if the ventricle decides to slow down, then your whole heart rate slows down. The atrium, the pacemaker cells are gone, basically. You have no longer any pacemaker, or the pacemaker is not communicating to the ventricle. So you're reliant just solely on your ventricle rate. And this is where it gets into things like junctional rate and things like that, which I'm not discussing. This technically is a junctional rhythm, meaning that the ventricles are running its own show. And that means that the rhythm is coming from the AV node rather than the SA node. And so this one worries us because the ventricle is not a very good pacemaker and it slows down very frequently. And third degree heart block becomes something that we might have to pace. And the reason being is that these meds that we use for bradycardia, atropine and dopamine, work on our pacemaker cells to speed things up. So atropine and dopamine will not work in a third degree heart block because your atrium's not talking to your ventricle at all. They're disassociated. So the meds don't work in a third degree heart block. In a first degree or a sinus brady or a second degree, we will have our medications work because we have some communication between the atrium and the ventricle. The SA node is still influencing the ventricle. So our meds have a chance to work. Atropine and dopamine. Atropine basically slows down your parasympathetic system. It blocks your parasympathetic system. So the AV starts, in third degree, the AV is basically controlling the ventricle. And it's like, dude, I never heard from the SA node. We don't know what's going on here, so we better do our own thing. And the AV node's not a very reliant pacemaker. The SA node's a better pacemaker, runs at a higher rate. The AV node, a junctional rhythm, or what the ventricle usually paces itself at, if the AV node's going to take over, is usually about 60 to 80. It's a much lower rate than our normal, and it slows down pretty easily. It's not a great reliant node. So we don't want our ventricle running the show. It's better than if it's not running the show. But the SA node is the controller. But the AV node has that backup ability. If it never hears from the SA node or it never communicates, then the AV node is like, okay, well, let's just run around 60. How about that? 60 work for you? And the ventricle is like, 60 works for me. And they run, at that rate. The AV node, though, is not, like I said, reliable, and it can slow down pretty easily. But the problem that we have with the meds is that atropine blocks your parasympathetic system, which is your rest digest system. So if we block rest digest, what's going to happen to your heart rate? When we have the parasympathetic system stimulated, it slows our heart rate down. It's causing us to rest. Calm down. It's all good. We're going to go digest now. We're all chilling. So your heart rate kind of slows down. If we block that signal, then your heart rate will speed up. But atropine works at the SA node. The SA node is what responds to that signal from your sympathetic parasympathetic system. So if our SA node is not communicating to our ventricle, then atropine's not going to work. So when you give atropine to a third-degree heart block patient, it doesn't do anything, because the SA node, you can turn it. So when you give atropine, let me go back to my third-degree heart block rhythm. When you give atropine to a third-degree heart block, what will happen is now you have a bunch of P waves, because now this, if it's responding at all, it's like, okay, tons of P waves. Yay, we slowed down. We're giving a lot of P waves. But the ventricle rate doesn't change, because there's not listening to the atrium anyway. Somewhere along the line, there's a disassociation. They're not talking to each other. And so atropine doesn't do anything other than create more P waves. It does nothing to your rate. So that's why we try the meds first. But if they don't work, and dopamine does the same thing. Dopamine doesn't block your parasympathetic system. It stimulates your sympathetic system, which causes, flight, causes your heart rate to go up. So what we're doing with these meds is we're stimulating the SA node to try and get it to go a little faster, to make the ventricle go a little faster. The only time the meds don't really work is in third-degree heart block. And then in that case, if the meds don't work or the heart doesn't respond to those two meds, which should speed up your heart rate, then we will go to the electricity, which is a pacemaker. And that's saying, all right, SA node, AV node, you had a chance, you're screwing it all up, we're going to go ahead and pace for you. And I have a couple of slides on all of those things. So we have our atropine, like I said, it's blocks parasympathetic, increases heart rate. Dopamine stimulates the sympathetic to increase heart rate. When I do call these out, go ahead and, these might be meds that are on a test for you. I'm not going to ask you correct safe dose and things like that on a test. I would just want you to know that they are appropriate for treating a bradycardia. These are our two meds of choice for treating a bradycardia. Here's some on pacemakers. Everybody's like, oh my God, our pacemaker's going to be on the test. I would like you to know that it is the appropriate electricity for a bradycardia. We only really use pacemakers for bradycardias. I don't need you to know troubleshooting a pacemaker. I think that's interesting information for when you go to class, but I will tell you, I have given so many classes to ICU nurses on pacemakers that I guarantee you your ICU nurses probably aren't good at pacemakers either. So I'm not going to expect, fourth block nursing students to be competent at pacemakers. So just kind of, let that go. Pacemakers are the electricity. It is low level electricity. It's not like a shock, but it is generally shocking the heart at a rhythmic rate. It's just a much lower electricity. You can do pacing any number of ways. You can put pads on. They're connected to the defibrillator. The defibrillator can pace. You will never do this. That is an ACLS physician skill. But you can pace a patient transcutaneously by putting on pacer pads, and that is an ACLS skill that they teach you, is how to put on the pads and how to use the defibrillator as a pacemaker. But you can put pads on the skin and kind of do small shocks. They are like tiny defibs, but they are much lower electricity. We're just trying to stimulate the heart to beat. They can put an IV into, or a pacemaker wire into the actual heart and try to stimulate the heart that way, or they can surgically implant the electrodes into the heart muscle. So this is just a picture of all three. This one right here, this is the transcutaneous. This means it's through the skin. This one is the venous one, where there's actually a wire through a central line that does drop into the heart, and we use that, and basically we're just going off of, hey, is the heart responding or not, whether it's in the right place. And then this is the implanted one. So that's the surgically implanted one that sits under the skin. And really just knowing that you can do 3 different kinds is pretty good information for pacemaker. Just so that you know, there are 3 things that are ordered by the physician when you do have a pacemaker. A mode. I'm not going to test you on modes. The easiest way to know this is that it tells you which chamber is sensed and paced. They should be the same. You should be sensing any chamber you're pacing. So AAI means only the atriums are paced. VVI means only the ventricle is paced, and DDD means dual. Both the atrium and the ventricle are paced. The mode is determined by the physician or by the pacemaker in there. You can't pace if you have let's look at this venous one. Where do you think the electrode is sitting on this one? On this bottom pacemaker. Where is that electrode sitting? It's in the ventricle. So the only chamber that is being paced right now is the ventricle on there. You don't have any extra electrodes. There's nothing else going on. So this would be set as a ventricle pacer because that's the only thing that's being paced. If you set it to pace atrially, you don't have an electrode in the atrium, so it can't pace atrially. So it's kind of dependent on what you're doing. This one right here, this can plant one in the atrium and one in the ventricle. And so it can pace 2 different, and so you can have different rates going out to each ventricle. They can be very complex, but the mode will tell you where the electrode is sitting, and it should be, if the electrode's sitting in the atrium and only pacing the atrium, you get AAI. If it's sitting in the ventricle and only pacing the ventricle, you get VVI. And if it's in both, it's dual, which is D. Don't worry about triggers, inhibits. That's way for more detail than you'll ever need. Rate is the rate. The pacemaker sends out the impulse at a set rate unless it's told not to by the heart. It needs to sense what the heart is doing so that it can not send out a beat if it needs to. That's what that triggers and inhibits means. But basically, a pacemaker is set. If you set a pacemaker at a rate of 70, it's going to fire its electricity at a rate of 70. Ka-tunk, 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 and stimulate the heart unless it sees something on the EKG where it's like, oh, you win? I don't need to go. So the pacemaker is supposed to read the heart rate. And that's what it's doing. It's sensing whether there's a heart rate or not and whether it needs to fire. The electricity is the amount of electricity sent out to the heart. So those things are set by the doctor. We put them in on the pacemaker. So those little dials there, the output is the amount of electricity that's been ordered. The rate is the rate that's been ordered. If it does have the ability, some of them are old dials to dial in the mode and things like that. Is AAI supposed to be AAT, where T equals triggers? So I will tell you that basically all pacemakers are set up as inhibiting pacemakers. Okay? They will go unless they're told not to by the heart. That is called inhibiting. They're supposed to inhibit when the heart goes. So if it sees a heart rhythm, it's supposed to inhibit itself from going. Triggers is special yeah, the chart says T for triggers. And I will tell you that that is really only used where we are using dual pacemakers, because what it does is it waits. It waits for a certain amount. So if it triggers the atrium, it stimulates the atrium, and then it waits for a few seconds to see if the ventricle goes based on what it told the atrium to do. And if it doesn't, then it triggers a beat from the ventricle. So it's very difficult and complex. Do not stress about that. I've never ever seen AAT. It doesn't exist. I is what pacemakers do. They inhibit. They go unless they're told not to. Trigger is for when it's saying, okay, you're going to, I watched the P wave. I'm going to see if the ventricle goes, and if it doesn't, I'm going to do that. Excuse me. I need to take a drink of water. So don't worry about inhibits versus triggers. All pacemakers are inhibitory unless they're on some kind of timer and they're waiting to see if the ventricle does. It's basically giving the chance for a ventricle to work. That starts to get really complicated, and like I say, trigger is not a very common mode. Inhibit is what pacemakers do. And when it's in that dual mode, it triggers and inhibits. That is because trigger is only supposed to happen when a ventricle doesn't do something after the atrium. And like I said, it gets very confusing. There's no such thing as AAT. It just doesn't exist. It is AAI. All pacemakers are I. The T is a special situation, so don't even worry about it. If you want more detail, we can set up an appointment and I can kind of show you a couple of different things, but I just don't want you to stress out about that. Pacemakers are inhibitory, and that's what they do. They go unless they're told not to by the heart rhythm. So those things are set, and then what the nurse manages is whether the pacemaker is reading the rhythm right or not. First of all, we make sure that the heart is responding to the electricity that's sent out, and that's the sensing. And then we adjust the sensitivity of the pacemaker. We don't decide electricity amounts. We don't decide modes. We don't decide rates. Those are physician orders. We only manage the sensitivity of the pacemaker. So, like I said, don't spend a lot of time on the troubleshooting of the pacemaker. But what we're seeing here is the pacer spikes is electricity being sent out. Okay? So we have a spike here and a spike here. We have a spike here and a spike here. That is electricity being sent out from the pacemaker. What you're seeing here is that the pacemaker is not capturing on this one. So you see electricity being sent out, and then you see a P wave. You see electricity being sent out, and then you see a QRS. Here we don't see any pacemaker spikes because the heart did its own thing. You don't need a pacemaker spike because there's a regular P and a regular QRS. So you're like, yay, we work, yay, the heart worked. Here we see electricity being sent out and a P wave. Electricity being sent out, oh, where's our response? What? We should see response here. This was electricity being sent out. Why didn't that stimulate something? This is a beat that should have happened. Something didn't happen here. The electricity the heart did not respond to electricity. So we're calling that heart failure to capture because it didn't do what it was supposed to do. When electricity is sent out, there should be a response. And what we're seeing here is no response. So that is a problematic area right here. Then we see electricity sent out, P wave, electricity sent out, QRS, great. We got a regular P QRS, so we don't need to send electricity. Electricity sent out, P wave, electricity sent out, QRS. Everything's good. This one right here, why in the world didn't it pick up the electricity and do what it was supposed to do? And that's something where, hey, maybe your battery's dying. Sometimes, they're run by batteries. If your battery runs down, it says it's sent out 10 milliamps of electricity, but did it really? Obviously, it wasn't enough to stimulate that heart. So the first thing we do when we see a pacer spike with no beat after it, when there should have been, is we kind of check the batteries, check the cables, check the connections. Something's not quite right. Or maybe the heart muscle couldn't respond to it. And sometimes hearts just get immune to a certain level of electricity, and they don't listen to it anymore, and you need to up the electricity to the heart. So anyway, that's just a thing. When you see a pacer spike without a beat, that is a problem, because it means we sent you electricity, you're supposed to respond to it, heart. What do we need to do to get you to respond to the electricity? The next thing that we have is sensing. Basically, pacemakers, like I said, are supposed to go unless they're told not to by the heart. So this one is, there's a pacemaker spike and there's a QRS. There's a pacemaker spike and a QRS. And wait, we have a dropped beat. Don't you think that a pacemaker should have gone there? A pacemaker that is set to go at a certain rate should have fired there. There should have been a pacemaker spike with a QRS after it, but it's missing. And it's missing because the pacemaker thought something had happened there and it inhibited itself. So it's too sensitive. It's seeing things that aren't there. And so we would just decrease the sensitivity of that pacemaker. It's too oversensitive. There's no real damage in a pacemaker being oversensitive, except that you get long pauses. Because basically this heart is dependent on the pacemaker for stimulation. Because it's not doing, the atria is doing its thing. This heart, this is a ventricle pacemaker. It could be atrially paced as well. It just doesn't need to go because it's doing its own atrium. We've got its own P wave going here, but it waits a couple of seconds, and if it doesn't see the ventricle respond, it's going to send this spike out and say, dude, you didn't go. I'm sending some electricity to stimulate you, and then that's the response of the ventricle. Because as soon as the ventricle sees electricity, then it's stimulated to go. So here's electricity stimulated to go, and it's supposed to be waiting after the P wave, and it's supposed to say, you didn't go, but it didn't do that. So the pacemaker's not doing what it's supposed to be doing there. It's just a little bit too sensitive. And the dangerous one is a pacemaker that's not listening to the heart at all. It's undersensing. It's not listening at all. I like to call the oversensitive one kind of the teenage girl. It thinks everything's a beat and it never fires. The undersensing one, you can see that this pacemaker is throwing electricity. If these are the spikes, it's just throwing spikes randomly. And it's not paying attention. It shouldn't be throwing spikes after a beat. It's putting electricity during the reset period. It's stimulating the heart during heart reset. After a QRS, there should be no electricity stimulating the heart. After the QRS, the heart needs time to reset. If you're throwing electricity after the QRS, you could fire something during reset time, which will send the heart into fibrillation. So we need to protect this. This pacemaker is not doing its job. It's sending out spikes where it shouldn't. It shouldn't have even gone there anyway. There's a QRS happening. Why is a pacemaker spike happening? It's not listening, and it's just doing its own thing. And when pacemakers start doing their own thing, we could get trouble. So anyway, again, don't spend a lot of time on this. It's an advanced concept. I just need you to know that pacemakers are the treatment for bradycardias. The electrodes are placed into either the atrium or the ventricle or both, and that the physician orders the mode, the rate, and the electricity, and we, the nurse, manages the sensing of the pacemaker. And so this is our job, is to make sure that if this pacemaker is leaving long pauses, then it's not doing its job. We need to make sure it's reading properly. And if it's sending electricity where it shouldn't be, then we need to sensitize this pacemaker and make sure that it's not throwing electricity where it shouldn't. So really, I'm not going to spend a ridiculous amount of time on pacemakers because you're not going to be running pacemakers. When we teach about bradycardias, we just teach the patient really the causes. and it's important for you to know the causes so that you can teach the causes. You could certainly have bradycardias because you have heart tissue damage, especially damage around the pacemaker nodes. You could just be not feeling that good and have increased vagal stimulation, increased parasympathetic stimulation, telling your heart to slow down. You can have meds that stimulate the parasympathetic system. If you have meds that stimulate parasympathetic, it's going to slow your heart rate down. Any meds that decrease your heart rate. So here's the magic of this, what I like to call my remit theory. It's how to recognize it, how to evaluate it, what your key symptoms or what you're going to monitor. When I say evaluate, you want to make sure that when you recognize something, is it getting worse or is it stable? And that's where we're going to evaluate. Are you asymptomatic or symptomatic? What you're going to monitor, I will tell you that evaluation and monitor is the same for every single heart rhythm. Interventions, again, these are all Brady's. We're going to give them medicines first and then give them pacemaker electricity. Okay? So that is the summary for bradycardies. Do you need a break or do you want to just keep moving? No thoughts? Crickets? Crickets? Go. I got one go. I'm going. Okay. Sinus tachycardias in a class by itself because it's all okay except for the heart rate. So the rate is 100 to 150. Let's see. This one is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. This rate is 140. So our rate is 140 there. It fits right in the sinus tachy. We look at everything else, checks out. There's a P before every QRS. Yep. People ask what's the difference between a P and a T. Well, hopefully there's just two of them. One's P, one's T. And yeah, so we're P before every QRS. Our QOS is narrow, normal. It's only one box wide, so we're good there. It's regular. These guys, there's no dropped QRSs. There's nothing wrong. We're all good, golden. PR width is 3 to 5 small boxes, and when we're measuring PR width, we're going to start at the beginning of the P. Ooh, let's go down here. And to the R, which is about here. So we're just measuring 3 to 5 small boxes. It's right about 4 or 5 small boxes. So we're perfect. This is a sinus tachycardia. Oops. Everything is normal except for the rate, and the rate is between 100 and 150. Again, we're going to ask our patient. You're going to get sick of this slide. We're going to ask our patient, check their pulse ox, ask them if they're short of breath, dizzy, and if they are symptomatic, we'll go one way. If they're asymptomatic, we'll just keep an eye on it. We're going to monitor all the same things. If they are asymptomatic, which mostly they are in sinus tachy, we're going to find and remove the underlying cause. You've seen this one. Exercise, anxiety, fear. I mean, hey, anything cause you to be a sinus tachycardia. If it is worsening and you are short of breath or you have a bad pulse ox or something, then your heart is just not working well with this. We will give you medicines to slow your heart rate down. The goal for every heart rate is to keep it, every tachy of any kind, keep the heart rate less than 120. Okay? What happens to a heart that has a heart rate greater than 120? Why do we worry when it gets greater than 120? Not necessarily that it gets big. It could if it did this for a long time. What's happening when your heart rate gets greater than 120? It can't fill. Good job. It can't fill. It doesn't have time. It's going so fast that its fill time has been cut down. So the faster your heart rate, the less you're actually pumping with each beat. So we want to keep the heart rate less than 120 because that is adequate filling time. Once you get greater than 120, then your heart's not filling, so how can it be pumping? It doesn't even matter how much fluid you have or don't have. The faster your heart rate, the less time it has to fill. So keep your heart rate less than 120 if you can, and that's really the goal with sinus tachy. There's really nothing wrong with your heart. There's something that is causing your heart to beat fast. What about athletes that had 195? Well, guess what they're not doing? They're not filling. So you are making your heart strong when you get to that point, but you don't stay 195 for longer than, isn't there like a recommendation of how fast your heart rate gets higher? Then, you're not supposed to keep it at that heart rate for a long time because it's not filling. No matter how strong it is, you just don't have enough time. That's why you get short of breath when you exercise. When you bring your heart rate up, you're becoming symptomatic. You're becoming symptomatic sinus tachy. You need to slow yourself down and get that heart rate back down. So if you've gotten short of breath while exercising, it's because you're not perfusing. If you keep doing that and you keep your heart rate up, you're going to pass out on the treadmill because you're just not filling. And yes, you're supposed to bring your heart rate up to challenge it. It's like bodybuilding for a heart. You bring your heart rate up, challenge it, make it work hard, build that muscle, but you've got to give it time to slow down or it can't fill. And if it can't fill, it can't perfuse you, and you end up getting short of breath. So when you're short of breath on the treadmill, give yourself a break, for goodness sakes. Let your heart rate come back down. Healthy people can tolerate it much longer than unhealthy people. If it won't come back down on its own, then we might need medications to bring it down. So really, all that sinus tachycardia, I'm going to reiterate the rate control meds that we have, and our rate control meds are beta blockers and calcium channel blockers. We're not worrying about the ARDs and the ACE inhibitors. The ACE inhibitors and the ARBS, those are blood pressure meds, but they work on the renal system. They don't stimulate or slow down our heart. So we're really using only beta blockers and calcium channel blockers as our rate control meds. They're the ones that physically work on the heart to slow them down. Does that make sense? So don't worry about your ACE inhibitors and your ARBs. Don't affect your heart rate. They just infect fluid. They're not our rate control meds. Our rate control meds are the blood pressure meds that slow down your heart. Beta blockers and calcium channel blockers. And so here's your summary slide for that one. Is he just special? He must have an amazing heart. He must have an amazing heart, Michelle. Give him a big hint. But, I mean, I don't know. We see a lot of bikers that have trouble and runners that have trouble as they get older because the heart's just not as strong as it used to be. But anyway, sinus tachycardia, we really want to keep it less than 120. What kind of trouble? Well, I mean, if you don't fill as the heart gets weaker, if he keeps his heart strong, then it's perfectly fine. That means that he's got great ejection fraction with each beat and that he has compensated with that high heart rate. And probably when he's not doing anything, his heart rate's probably like 40. He's just at a very efficient muscle, and so it pumps well under that pressure. If you stop training your heart at any point, and you try to go back to what you do, that's when people have MIs when they work out. They had their heart trained so that it had a great ejection fraction, that it was pumping and it could pump really well at a high rate. And then you stop and you slow down, the heart muscle gets weak again. And then they go back to train and they go back to doing what they used to do. And then they become symptomatic, but they don't believe because they didn't used to be symptomatic. It's, we see a lot of people that have MIs that go back to train and think that they were 30 years old. You have to keep that rate up. But if his ejection fraction is so good that he is efficient and that you can pump quickly, and you've learned how to fill quickly, then, that's great. Just tell him to not get lazy and then go back and train at high speeds. You have to ramp yourself up. So basically, here's your summary for tachycardia. And all I'm showing you on these is recognize it, evaluate and monitor is exactly the same. Your treatments are a little bit different. Asymptomatic treatment doesn't change on any of these. Symptomatic treatment, the meds are different. There's no electricity for sinus tachycardia. Okay? We don't shock or do anything with sinus tachycardia. We don't pace it. We just slow it down. Atrial. This is where we have something wrong with our P wave. Okay? Something is wrong with our P wave. Bradycardia, something's wrong with our PR intervals, or the rate is just slow. Sinus tachycardia, everything's okay except the rate. Atrial dysrhythmias is something's wrong with our P wave. So there's a premature atrial contraction. This is where you have a QRS that doesn't have a noticeable P wave in front of it. This one's very hard to come across. It's basically everything looks normal, except you can't figure out what the heck is going on here with these P waves. So you're going through with your rate. Let's look at this one. 1, 2, 3, 4, 5. This one's actually got a rate of 50. I might throw that in the bradycardia bin. But right here, we're looking, this is a normal P wave. So this is what our P wave looks like. Some people will be like, that's a P wave, that's a P wave, that's a P wave. And that could be, but then we have a dropped beat. So this one would be very hard for me to tell the difference between it being a premature atrial contraction and whether it is a block or not. Because this is our, if we take this as our regular, then I should have, this is a dropped beat, right? Because if these were regular, this is a dropped beat, and that would qualify as a block. Because this one has a rate of 50, this probably isn't the best strip. I'll try and find another strip for you. Because this one has a rate of 50, I would probably classify this one as some kind of block. At this point, I probably wouldn't call that one a premature atrial contraction. So I'll try and find something that's a little bit better. But basically, it's a QRS without a noticeable P. There's something, they went too early. And so really, this, I'm going to find you a better, let me find a better rhythm, better strip for PAC. So there's a P wave before every QRS, but then there's something. So let me come back. I will find a better strip for this one. Because this rate is 50, this one really should get thrown into the bradycardia block and is not a good strip for premature atrial contraction. I don't know. Maybe I was drinking too much wine when I put this together. We'll come back to premature atrial contraction. I actually have an in real life version of it. Let's look at AFib, because this is the most common one here. Atrial fibrillation, the first of all, so you're going through, you're looking at your rate. You're like 1, 2, 3, 4, 5, 6, 7, 8, 9. So our rate on this one is 90. So we got our rate. P wave before every QRS. Now you could sit here and make a case for P waves if you want. You know, is that a P wave? Is that a P wave? I don't know. So you're like, I don't really see anything organized. I don't see a nice P wave. So I'm going to just keep going through my checks. My QRS is okay. It's narrow. Is it regular? So then we start looking. Let's go here to here. And if this is 2, 3, 4.5 boxes, and then we go 1, 2, 3, and then I've got a rate here. That one's a little shorter. This one's even shorter. And then we've got longer, and then we've got longer. And I'm like, all right, I've got all kinds of irregularness here. This is not, this is short. We've got short, long, short, long, short, long. It's irregular. And combine that with I can't read a standard P wave. We kind of stop here, and we call it irregular. And no P wave that I can tell, we're going to call this one fibrillation. And the reason we call this fibrillation is because that's exactly what the atrium is doing. There's no nice P wave, okay? Don't spend a lot of time on an irregular rhythm. Don't spend a lot of time looking for that P wave if it doesn't exist. This is a fibrillating atrium. And so the ventricle's trying to figure out, like, is that, should I go? Should I go? Dude, did you go? Did you mean to do that? But the atrium is fibrillating up there. The atrium is just doing its own thing. And there's no organized message going down to the ventricle. So the ventricle's trying to follow the best it can, but since there's no organized rhythm, the AV node kind of has to interpret what's getting down to them. It's basically the atrium is trashed. The atrium is fibrillating, and it is not contracting appropriately. It's not conducting appropriately. The atrium is fibrillating, and so it's called atrial fibrillation because that atria is just quivering up there, and the electricity is not making it around in a nice hump. So if you wanted to call this a block, you would need a solid P wave that you can measure. There's no solid P waves here. If it's just junk, it's just junk, okay? You can call it AFib if it's irregular. Does that make sense? This one is atrial flutter. and this could be called atrial tachycardia. This is the atrium, so you're like, okay, this is a P wave. Oh, let me go back. I keep going to draw, and then it forwards my screen instead. This is, so you're like, okay, this is a P wave. This is a P wave. This is a P wave. Atrial flutter looks like multiple P waves, and sometimes they do call it 3 to 1, 2 to 1, 4 to 1, 5 to 1, because there are multiple P's. And so it's not really a block because you're getting consistent numbers of P's before every QRS. This is basically the atrium is tacking along, and the AV node lets forth every third or fourth rhythm, and they're like, okay, we're going to go every third or fourth one since it's going so fast up there. So this is atrial tachycardia. We also call it atrial flutter because the ventricle is you could call it, if you just had no QRSs in here, you would be having what looks like a VTach going on. This is an atrial tachycardia. There are multiple P waves. They look jagged. It looks like a sawtooth thing. It looks like literally a saw. And what you're seeing is every 3 or 4 P waves, a ventricle beat goes through. So yes, you have P waves, but you are having multiple P waves per QRS. Okay? Atrial flutter is regular because it's letting every 2 or 3 through, but there is no PR width to read because there's multiple P waves. You can't read the PR width of just the one closest to it because that one is, you can see the PR width. I mean, you could read the PR width of it, but you're not going to call it normal sinus rhythm because you're having multiple P waves. And they look jagged and sawtooth. So usually as soon as you see this jagged sawtooth pattern, we go with atrial flutter. It is usually regular because, like I said, sometimes they will call it 3 to 1 or 4 to 1 or 5 to 1, depending on how many P waves you have. But the issue is that this P wave is not normal. It's not just one P wave. This one has no P waves. It's just fibrillation. There's nothing noticeable. And you're like, but I want to call that a P wave. None of them match. So let's say, oh, I really want to call that a P wave. I love that one. But there's no other one that matches it. You're like, maybe you're just trying to make a case for something that's not a P wave. A real P wave will be a nice hump like that. On this one, you have multiple P waves, and they're usually in a pattern. 2 to 1, 3 to 1, 4 to 1, and that's atrial flutter. Because what's happening underneath here is either the atrium is tachycardic or the atrium is fibrillating. So these are atrial problems. Does that make sense? And every single one of these has a normal, narrow QRS. Every single one of them. Here we have some atrial. Like I said, I'm not in love with this one. I might even call this one a block because of its low rate. I will find you another PAC one, and I have one to show you. This one's AFib. This one's a flutter. And we put this one here. Supraventricular tachycardia. This is any heart rate greater than 150. We don't know what's underneath. This heart rate is so fast. This could be sinus tachycardia. This could be AFib. This could be a flutter. This could be it's going too fast to see the P waves. We don't know what's underneath it, but we know that our QRS is narrow and normal. So we are calling it supraventricular, meaning above the ventricle. Something's wrong with the atrium. The atrium is making this super tacky. You might hear this called rapid ventricular rate, or RVR. This is anything over 150. So when you're training and you've got your heart rate up to 95, you are technically in SVT. We just don't know what's causing the SVT. But because the QRS is narrow and normal, 1 to 3 small boxes, we need to figure out what is happening. It's too fast to tell what the PR width is. We don't know what is causing this. because it's so fast, usually people have a decreased cardiac output. The heart doesn't have time to fill. It's usually symptomatic. If you're not symptomatic with it and your heart rate returns to normal after you stop doing what you're doing, then it's not a concern. If this heart rate is too high while you're at rest, you have a concern. So we have a little bit of a different treatment for SVT, but we put it in the atrial arrhythmias because it uses the same electricity as the atrials, and it uses the same, a lot of the same meds as the atrial arrhythmias. So it is an atrial rhythm. It could be sinus tachycardia that got too fast, but a lot of times what you will see these named as, after they've slowed down the heart rate and they can look at the PR interval, you will see this called AFib with RVR, or a flutter with RVR, or and that's what they mean, is that they had SVT, we slowed it down, and we could see that the underlying rhythm was atrial fibrillation. A lot of these supraventricular tachycardias come when the ventricle starts listening to that atrium that's fibrillating or super tachy, and it answers it beat for beat, and it gets kind of high. So we put SVT in the atrial arrhythmias, but anything greater than 150 technically gets the SVT label, because it is super tachycardic. So again, I'm not going to go over this slide again. We know to check our patients to see if they're symptomatic or asymptomatic. Your athlete that's exercising may be a little short of breath, but after they cut off and they start talking to you, everything gets better. They become asymptomatic, then you don't have anything to worry about. If they remain symptomatic, we have to do something. So the meds for these, for your asymptomatic patients, so they are in AFib or a flutter, which are our main fibrillations. We don't usually treat the premature atrial contractions because they're just premature. They're just every now and then. We really treat the patient that has atrial flutter or atrial fibrillation. And that patient, even though they're even though they're asymptomatic, they may be on meds that keep them under control. Why do you think we want anticoagulants on an atrial dysrhythmia problem? So looking at these guys. So Michelle says blood clots, which is actually true. Why in the world would we get blood clots? So it's not fully ejecting. When this atria is fibrillating here, it is just quivering. So blood is continually filling it, and blood is continually dribbling out of it. But there is a lot of blood just sitting there, not getting pushed out. And so, yes, there is stagnant blood in the atrium. And that causes you, with any fibrillation or with any flutter, it's not being ejected fully. There is stagnant blood in the atrium, and so we are at much more risk with atrial arrhythmias of clotting happening. So patients can live in these rhythms. They're not always treated, but they want to make sure that their rate stays under control and that they get anticoagulants. Patients live in AFib and A-flutter all the time. We actually have, some people have a genetic atrial appendage, which is an extra pacemaker cells, and those sometimes misfire and give you atrial fibrillation, atrial flutter. Sometimes it's undiagnosed because it's completely asymptomatic. Just all of a sudden you have a rapid heart rate all the time, even at rest. If you do have this problem, if you have an AFib or an A-flutter, even if you're asymptomatic, once you've been diagnosed with atrial fibrillation, atrial flutter, they will probably put you on anticoagulants and rate control if you stay in those rhythms. If they cannot get you out of those rhythms, they will put you on anticoagulants and rate control. And that is because we want the heart to fill, and we want the stagnant blood to not clot. So most patients with atrial fibrillation, atrial flutter, if they're living in that rhythm, I'm not talking about if they convert to normal sinus rhythm, but if they're living in AFib or A-flutter, they will be on an anticoagulant and rate control, even if they are asymptomatic. If they are symptomatic with that rhythm, then they will get oxygen, of course. Anybody who's symptomatic gets oxygen. If you are an SVT, we don't want to stimulate a heart to slow down. And again, vagal maneuvers aren't going to work in an atrial fib or an atrial flutter because our pacemaker nodes are fibrillating or fluttering. But in an SVT, you can ask them to bear down and hold their breath, because if it's a sinus rhythm, a sinus tachycardia, it may slow down. You may be able to stimulate, and what we're doing is we're stimulating the parasympathetic system, rest, digest. We're stimulating the parasympathetic system to try and get the heart to slow down. You can do vagal maneuvers on anybody. It just probably won't work unless it's SVT. It's the first thing to try, though, if your heart rate's greater than 150. We don't need people bearing down with a heart rate of 120, but if it starts to get to be above 150, you can ask people to hold their breath or bear down. The medications are going to be your rate control meds, slow down the heart. Now we've added a different one in here, amiodarone. We have calcium channel blockers, beta blockers. We use those for sinus tachycardia if we need to. We can still use those as rate control meds. We have an antiarrhythmic now showing up. Amiodarone works for atrial and ventricular arrhythmias. This one is actually going to calm down those wayward cells, stop them from fibrillating. It's an antiarrhythmic. They will also get anticoagulants as well as asymptomatic people that are living in the rhythm. And then there's a special med for SVT only called adenosine. So we'll talk about that. If we cannot get any of our atrial dysrhythmias under control with medications, then the electricity form is cardioversion. Cardioversion is conscious defibrillation. The patient has a pulse, but we are going to defibrillate them. So we defibrillate them basically timed. And then if none of that works, or they're getting constant cardioversions, they're constantly going into rhythms that we don't want them to be in, or they're constantly having high heart rate issues, there are surgical procedures where they can go in and burn off or remove those extra pacemaker cells that are causing trouble. So we're going to talk a little bit about the anticoagulants are here again. Remember, they're only here for the atrial people who are living in atrial rhythms or, A-flutter, AFib will get anticoagulants just to prevent any clots from forming and causing strokes. Amiodarone is an antiarrhythmic. It is IV and PO. You will see it used in the ventricular ones as well. And it basically slows your heart rate down, prolongs the PR intervals, prolongs the QT intervals, and Mark said something about adenosine being the only med you could push center because adenosine is a sin. You could definitely, adenosine is, you can push anything super fast if you're coding, but adenosine or adenosine is our chemical code drug. Like basically, adenosine will stop your heart. So here on our next slide, I kind of go through here. Adenosine, if you ever get to see adenosine being used, it's only for SVT. So any heart rate greater than 150, we can try adenosine. What adenosine's going to do is it chemically stops your heart. Okay? You don't want to do that, but it has a quick half-life. It only lasts 6 to 12 seconds. So you have to push it super fast because you want it to work. And what it's going to do is it basically slams the heart to a stop. And then because it wears off in 6 to 12 seconds, you should only have a 6 to 12 second stop. And I love the memes that go with adenosine. It does slow the conduction of the heart down, and it is a chemical cardioversion is what it is. We only use it with symptomatic SVT. So remember, your heart rate has to be 150 before we try it. They will probably try your rate control meds first before they're going to go to adenosine. So remember, you have a whole list of meds. They will try amiodarone, calcium channel blockers. The calcium channel blockers are the very nice meds. You have your diltiazem, verapamil, nifedipine. These are calcium channel blockers. They'll try those first. They really only go to adenosine when nothing is working and your heart rate is still greater than 150. Because what it's going to do is it's going to stop your heart for literally so a whole 6-second strip of no heart rate or 1 to 2 beats. The patient will, and that's why expected side effects of it are facial flushing, dizziness, nausea, lower BP. We stopped your heart for 6 seconds. Your blood pressure is going to drop a little bit. You tell the patient, now the patient's conscious for this usually. We're going to say, we're going to give you something that's going to make you feel really sick to your stomach, and you might get a little dizzy for a second, but it'll wear off in 10 to 15 seconds. So what we do is, yes, you have to give it fast. It's not really a sin. It's a last-ditch effort to get the cart restarted before we start going to electricity. So it's a pretty strong med. We'll use it in the arsenal before getting a defibrillator out to cardiovert someone. But it only goes for SVT, for super fast heart rate. We're not going to put an AFib of 120. We're not going to use adenosine. An AFib of 140, or if you can tell it's AFib, we're not going to throw adenosine on it. The only purpose for adenosine is to slow the heart rate down enough that we can figure out what's going on underneath it. And that's usually what they'll do in the ED or the ICU, and then they call it RVR. They say, oh, it was AFib with RVR, because they gave it adenosine, they slowed down the heart rate, they could see it was AFib, and then they start treating the AFib. Adenosine's a 1-time, 2-time use. It's really a diagnostic tool. It doesn't really stop the heart before it kills itself, because what we see happen a couple of times is that they go right back into SVT, but at least we saw what was underneath it, and so we can start treating it appropriately. Like I said, and sometimes it does reset everything. So adenosine is, if you want to use it's a sin, and it's the only one you push past. The reason we push it fast is because it only has a half-life of 6 to 12 seconds. So you have to push it in super fast and throw a flush right behind it, because you want the heart to get that whole dose, slow down, and then have everything come back. So anyway, adenosine is there for when we have a super high heart rate, to basically slow it down, hopefully reset it, but at least slow it down so that we can see what's underneath it, so we can start treating it. And then if none of those work, or they don't want to use adenosine, and they're like, you know what, we're just going to go ahead and go to cardioversion, this is an electrical reset. And the important thing to remember, the difference between cardioversion and defibrillation, it's still the same patches, it's still the same defibrillator. What you're doing is someone who is ACLS or qualified, and actually a doctor is with you when you do this. This is not really an emergency thing. This is a planned procedure. Is that the patient has a pulse, and we are synchronizing our shock so that it doesn't go in the wrong part of the cardiac cycle. After the QRS is the wrong part of the cardiac cycle. If we throw electricity right after the QRS and in the T wave, we can make the heart fibrillate. So this is synced so that it goes at the right, it times it basically, and throws the shock at the right place in the EKG. Patient should be sedated. You're about to shock them. It hurts. Being shocked hurts. If you're pulsed and you have a rapid heart rate anyway, and you're a little short of breath and you're feeling symptomatic, the last thing you need is them to be like, oh, we're going to shock you, and it hurts. So we can sometimes give sedation to these patients just because we're about to shock them with quite a bit of electricity, and it does hurt. But it is synchronized, so it reads the cycle. It reads it and then sends out the shock at the right spot. And then it's basically electronically resetting the heart. So both of these, the adenosine and the synchronized cardioversion, are ways for us to just stop the heart briefly and let it reset. So you can see this patient here has a heart rhythm that was super, super fast. It actually looks like a flutter to me, because we've got like a 2-to-1 thing going on there. He's got super fast. It says AFib, but I might even be tempted to call that one flutter. But either way, it's an atrial arrhythmia. Obviously, the patient was symptomatic with it, or we wouldn't be going to electricity. They probably tried a couple of meds to get the heart rate slowed down, and they finally decided to do a cardioversion, a shock. But it is synchronized. So sedate your patient, and then I let you watch the video. Cardioversion in real life. I'll let you watch this one at home. Keep an eye as you're watching it, though, on his heart rate in the upper corner here. As you're watching it, keep an eye. I mean, it's fun to watch his face too, but then when you go back and watch it, this patient is awake, alert. Watch his heart rate on the monitor over there as they shock this patient. Very similar to giving a patient adenosine as well. The heart rate will do the very same thing. So I'll let you watch that on your own right after class. You can go through and watch that. But I just want to get through the rest of it real quick. Many causes of atrial dysrhythmias. Again, I don't like that rhythm. I'm going to get rid of that rhythm. Ventricular rhythms. The thing to remember ventricular rhythms is they usually don't have any P waves, and they have a wide, weird QRS. This is a great picture of just a premature ventricular contraction. It's just a random, big, wide beat in the middle of nowhere. It's just a random ventricle. A ventricle cycle got a hold. Some ventricle cell decided it was going to be a pacemaker for a beat and threw out a thing. The ventricle responded to it, and then the atrium's like, I don't know what you were doing down there, but I'm going to go back to my thing. It's just a random ventricular beat is what it is. You can tell that it's ventricular because look how wide it is. One, it looks weird and abnormal, but here, this QRS, look how wide that is. That is like 4 boxes wide. And then it's got like this random thing because it's resetting funny. So QRSs, I mean, they're very noticeable. Premature ventricular contractions, they're very normal. And they're not very normal, they're irritable. Usually irritable hearts have premature ventricular contractions. Usually ventricle pacemaker cells don't do their own thing. And the reason it looks upside down and wide is because it's coming from a ventricle source. But any ventricle rhythm, the QRS is wide and weird. It's not narrow, normal like the rest of them. This is wide and weird. So that's just a random one. And then here's a whole bunch of wide, weird ones. This one's VTAC. They're all wide, they're all weird, but it's pretty regular, right? These right here are, they're all wide, but they're all regular. They all look almost exactly the same, but they are wide and they are weird. There's no P waves. The QRS is not narrow. It is wide. These have, you can count the rate just like on every other one. This one has a rate of 1, 2, 3, 4, 5, 6, 7. This one's got a rate of 160. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This one's only got a rate of 100. That one's really fast. I'm not even going to count that one. But you can count the rate on them. But they are wide QRSs, and they are pretty regular. There is no PR. There's no Ps. Just these wide, weird things. Now, a lot of you will want to go in and bring the code card into this room. I will tell you that VTAC, because it is somewhat regular, can be pulsed or can be pulseless. So this is where you're very much going to go in and take a look at your patient. I've had patients with long runs of VTAC that are completely conscious. It's certainly something to watch, but you have to go and assess your patient when you see one of these rhythms. This patient with this VTAC rate of 100 right here, that patient could be perfectly normal. It's just that their heart has shut down to the point where the ventricle is the only one creating any kind of rhythm, and its rate is 100 right now. So that would be a patient that we need to watch, but it certainly could be conscious and asymptomatic. So check your patient with any of the VTACs. You will recognize ventricular rhythms because they're wide and weird looking. Anything wide and weird you throw into the ventricular column. All of the atrial rhythms had that narrow, normal QRS. You can throw it into atrial if it's narrow and normal rhythm, and you throw it in ventricle if it's got a wide QRS. Again, you're going to ask about symptoms. So they really only have PACs or VTAC. Those are the only 2 ventricular rhythms that we've got. And for these, most of the patients are symptomatic. If you are asymptomatic, then you will certainly do testing and notifying the provider if it's a new rhythm. But if they are symptomatic in any way, shape, or form, oxygen. And now the treatment for ventricular arrhythmias isn't so much rate control, because remember those work on the SA node to slow you down. We're going to just use antiarrhythmics. So amiodarone is ventricular and atrial antiarrhythmic, and then lidocaine works in the ventricle only. Magnesium, so I think I said monomorphic and polymorphic. I think I wrote that down on here. Both of these are monomorphic because you can see they're the same. There's only one kind. They're all the same. So we're going to call it monomorphic. It's from one source. This one is polymorphic. It's big. It's really big. It's tiny. It's big. It's really big. It goes through a pattern. And polymorphic VTAC is usually due to a magnesium deficiency. I don't know if you got that along the line with magnesium, but polymorphic, it's called torsades, and it gets small and then big and then small and then big and then small and then big, but it is regular looking except for the amplitude gets small and then big. In that case, we will try magnesium on those, but you may get amiodarone and magnesium, you may get lidocaine and magnesium, but the monomorphic ones will just get antiarrhythmics. If those don't work and don't slow down the rate and get you back to normal, then you will cardiovert this patient just like you would with the atrial arrhythmias. And so there's our little PAC again. And so we have a table for those as well. So I really want you to be able to look at them, and I want to practice and play a little bit with a couple of rhythms. It's 2 o'clock. I guess maybe we'll start the class tomorrow with those. Pulseless dysrhythmias, I'm just going to point out. So again, if you have a VTAC but no pulse, you have a pulseless rhythm. If you have any VFib of any kind, now you may want to call this one a VTAC, but it's not very tall. It's very kind of small. It looks almost like if there's just that atrium was doing its thing on its own. Any kind of VFib, they're called coarse VFib and fine VFib, but either way, it's not that regular. Anyway, it's ventricular and it's fibrillation. This is always pulseless. So when you see any of these rhythms, these wide, weird rhythms, check a pulse. Check a pulse first. Make sure your patient's awake. If they are not awake, you are unresponsive and pulseless, and you go to code. You can also have asystole, which is no rhythm at all. You can have a perfectly normal, I didn't put a picture of pulseless electrical activity because it could be anything. It could be a block. It could be a normal sinus rhythm, but there's no pulse. So on that one, it'll say there's no pulse with this rhythm. And pulseless dysrhythmias, you've probably gone over before. Here's your code stuff. Here's a review. I'm not going to make you memorize code drugs at all. That is for ACLS. So if you're taking ACLS, it's a nice summary of your code drugs. But really, your job, call the code blue, CPR, oxygen, defibrillation. If it's a ventricular rhythm, you can defibrillate it. If it's pulseless electrical activity or asystole, you cannot defibrillate it. I'm not going to have you memorize code drugs, but those are the code drugs if you're interested. So that's pulseless, and just placing the pads exactly the same as you would with cardioversion, except that you are not syncing it. You're just throwing electricity onto it. We don't need to time it. The patient is not conscious. The patient has no pulse. You just throw electricity at it and see if it works. This is the only time you do Edison before medicine, is when the patient is dead. Otherwise, you do meds first and then electricity as your last resort. Here, when your patient is pulseless, you do electricity first and then you go to code drugs. So you can see here, defibrillation goes before drugs. Dead patients get Edison before medicine. Otherwise, you do medicine before electricity. You don't need to memorize the H's and the T's, but there's only 12 reasons you die. And there they are. Those are the 12 reasons that someone will stop a heart. And so that's what, during the code, in between drug doses, we're trying to figure out what caused the heart attack, what caused the arrest, or what caused the problem. And that is our H's and T's. But you don't need to memorize those. And we will talk about the rest of this. Let me see how many more slides we had to go. We'll talk about the rest of this when we get back to class. We don't need to see my Spotify. I just want to see how many slides we had left on this one. Oh, we only had a couple more slides. We're almost as done. So I do have probably 1 or 2 questions on, maybe one, on return of spontaneous circulation, because you did such an amazing job that you got the heart back. And the key is that you maintain oxygen blood pressure and send them to the cath lab if they need to go to the cath lab. If they do not, then we decide whether they need hypothermia or not. So patients that get return of circulation, they're either going to the cath lab because they had an MI, or they're going to the ICU for hypothermia. If the patient is conscious after returning to circulation, then we will just continue to monitor them. So that was just one piece of when you return circulation, usually the next step is either PCI or hypothermia. So I'm going to leave that at that. Let me show you one thing. So if you're watching this recording before next week, let me go to, I'm going to share on here. Oh, go away. Come down here so I can see you. I would love for you to go and play this. I can do this for a couple of minutes if anybody wants to stay behind. I will put the link in the modules, but it's heart, HEART.org, and then /ECC student. This is the ACLS pretest, and you put in the code ACLS 15. I'm going to give you a ACLS pretest for free. I'll put the stuff in the module so that you know how to play it. Don't worry about all the attention stuff. You don't have to put, this is for if you're going to do this prior to going to ACLS class. But how to fix Jose Garcia. We'll talk about Jose Garcia next week. You worked ahead, Melissa. We will fix Jose Garcia. Oh, wait, or is he Charlie? Which one's Jose Garcia? Is he, you made a terrible mistake and signed up for ACLS? It's not a terrible mistake. It'll be great studying. He's the last one. In clinical or in, oh, he is in the mini clinical. I will tell you. Don't worry. We'll fix him. But I'm going to just run through this. I'm going to go ahead and just keep recording this. So if you want to leave, you can leave, and I will record this. But I want to go through and show you how we do this. So the first section of this, and you could put it, you could just put in, AB. You can put in whatever. This just is what you would print off. The first part is rhythm ID, which I think that's the only thing you need to do on this. But I like the fact that, one, it marches out a rhythm for you. And I don't know if it's showing, but it basically just keeps going. This rhythm just keeps going. If you click on it, it will freeze and blow up so that you can take a look. And these are little calipers that you can measure with. So it will freeze the rhythm here for you and let you take a look at it. Any ideas? Any thoughts? And there's all these choices, so you can test yourself. Any ideas? Any thoughts? Anybody left? I got a VFib from Todd. Everybody's agreeing VFib. So let's do it. Where is ventricular fibrillation? I agree with you all. There it is. And you get instant gratification. Yay, you're correct. Look how good you guys are. Let's go to the next one. What do you think? Let me pause it. Yay. Like, oh, they're throwing all the good ones at you. Yeah, this person's dead. Okay, next. All right, let's freeze it. What do you think? It's a 6-second strip. We could start counting, but we get really tired. So yeah, we're going to call this one SVT because, one, we have a rate, like, let me even see if I can count this one. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25. This rate is 250. So it's really high. And is it have a wide QRS or a normal QRS? So it's either, at this point, VTAC or SVT at this high of a rate. What differentiates it is the normal QRS. It's only 1 box wide, so we put it into the SVT category. If it was wide and wide QRS, it would go into VTAC. But we're putting it in SVT, and so we can give it SVT. And we would be correct. So you can go through and do this. I just think it's fun. There's also an EKG Ninja, like ABG Ninja. There's an EKG Ninja that you could certainly test yourself on rhythms. So Todd's like, that looks normal to me. We just go through and do our 1, 2, 3, 4, 5, 6, 7, 8. This rate is 80. So I am happy with the rate. The rate is 80. We have a good QRS. We've got a PQRS, 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 PQRS. So I'm happy here. We look at the normal narrow QRS, and we're looking at the PR intervals. Let me do from here to the R is right here. We have 1, 2, 3, 4, 5 boxes. So do we have a normal PR interval? We're normal, so it is sinus rhythm. So once you go through your whole checks, you can kind of decide what to call it. And normal sinus rhythm. Yay! Look how good you guys are. You're passing ACLS. All right, now we got a tricky one getting thrown at you. Will you have strips on the test? You will have strips on the test. They just will not be any blocks. You will have some strips on the test. Yes. So let's do a rate. 1, 2, 3, 4, 5. Our rate is 50. So we can throw it right into a category right now. It's in the Brady category. So if I was asking you what to do with this, we would go through our Brady meds, which are either adenosine, dopamine, not adenosine, sorry, atropine, dopamine, or a pacemaker. But let's name it. What do you want to name it? You want to name it a Mobitz. All right, let's see what we've got here. So we know it's a Brady. We know it's not a sinus Brady, so we probably have some kind of block. So this wouldn't be on your test, but let's do our check of our PR interval. We have a P before every QRS. P, QRS, P, QRS, P, nope, P, nope, P, QRS, P, nope. So we've got a lot of nopes going on here. So I'm starting to think that we're not a type 1 because type 1s don't have any drop beats. We are not a type 3 because a third degree. So first degree and third degree don't have any dropped QRSs. So we're not a first, we're not a third. So we're going to get rid of all these, and I need to take a look now at my PR interval. So we can rule out first and third because those don't have any drop beats. So this is 3 boxes. This one is, oh, and I just went to kind of the PQ interval. That's not really technically correct. This is really the R. 1, 2, 3. So we'll do 4. This one is to here, to here. 1, 2, 3, 4. I'll call that around 5. Then we have nothing. And then we have nothing. And then we have, that's hard when you're right in the middle of this. Let's try here to here. 1, 2, 3. We can call that about 4. And then nothing. And then 1, 2, 3, 4, 5. So we're right around 4 to 5, and I'm kind of guessing at these. So I'm going to call this one, do we have longer than we drop? Or do we have dropping randomly? Randomly. So we're going to call this what kind? So is it a Mobit type 1 or a Mobit's type 2? I think it's 2. And you are correct. Look at you guys doing blocks. Good job. So you're already better than a ton of ICU nurses right now. All right, what do you think? I'll let you take a look at it. You can blow up your screens. You can play with it. Our first check is rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we're at 110 is our rate. So a little fast. Do we have a P before every QRS? I don't know. Maybe. Are we making cases for things? Are they even? I'm not going to make a case for these. None of these look the same. The only one that I think that looks like a P wave is that one. And maybe that one. Maybe that one. But the difference is that there's nothing consistent here. Okay? I'm not sure. None of those look the same. It is an irregular rhythm with a normal QRS. So what do you think I want to call this? I think there's something wrong with my P waves, and I think I have a normal narrow. So I think there's something wrong with my P waves. It's normal and narrow. It's irregular. I am going to call it atrial. I'm not going to call it a block because blocks have clear P waves, okay? Clear P waves that I can read. This has no clear P waves. I'm not really even sure if these are good P waves or if they're just too wavy. So yes, this one is atrial fibrillation because this, if you look at all of this under here, this is a wavy baseline. It's irregular. It's short, it's long, it's short, it's long. But it is definitely in the atrial category. There's something wrong with my P waves. So to call it a block, you need clear P waves that you can measure. If you can't and it's got a normal rhythm, then you just call it AFib. It is what it is. It is wavy, it is weird looking, and you would be correct. It's an atrial fibrillation because that atrium is not doing anything regular at all. These are really hard, guys. If you're getting these right, you're doing great. Now see here, this has a slow rate. This one has a rate of 50. So we're already throwing it in the Brady bin. Does it have clear P waves? It does. Those are clear. There's not a lot of junk around there. They're pretty clear. That one's a little smaller than the other one, but they're all just single, and they pretty much all look the same. There's a P before every QRS. PQRS, 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 PQRS. No dropped things. So we can either call it sinus Brady, or we can take a look at the PR interval. And let's look at the PR interval. Let's get one that's on a line. I like looking for ones that start on a line. This one's kind of starting here. and go into here. So we have 1, 2, 3, 4, 5, 6. This one's kind of starting here and going to here. 1, 2, 3, 4, 5. This one's starting in between this one and going to here. 1, 2, 3, 4, 5. So they're all pretty even. I'm kind of varying on where I'm starting these. This one goes here to here. They're not full boxes. 1, 2, 3, 4, 5. They're all about 5.5 boxes. So if it's even, and it's right at 5 to 6 boxes, what do we want to call it? Do we want to call it sinus Brady? It's kind of right on the edge. Let's see if it gives me a choice for sinus Brady, because that's what I want to call it. It's either a sinus bradycardia or a first-degree heart block. And I don't see first-degree heart block on my list, so I'm calling it a sinus Brady. And we would be correct. Good job. So again, like I said, go through here. If you come across a strip that you don't understand, or don't understand why they gave it the rhythm that they did, you can send me the strip, and I'll be happy to look at it with you. What do you want to call this one? I probably only have like a few people left in the room. So why do we want to call it a flutter? Do we have a normal narrow QRS? Because remember, to put it in the atrial category, we need a normal narrow QRS. Yeah, I'm kind of going with, yeah, we don't want to call this one anything atrial because I don't have a QRS that I can see. There isn't a single QRS. This one could be, because there is some activity, they could call it a fine V-fib. It could also be agonal rhythm asystole. I really wouldn't make you choose between the two. I think, just because I've taken this test 5,000 times, I think they want V-fib. I think this is a fine ventricular fibrillation. And it actually looks like you're not wrong. It could be an AFib. If we had normal narrow QRSs, that would be what atrial fibrillation looks like underneath. But this is basically total fibrillation. And so I'm going to call it V-fib. I wouldn't harm you for calling that agonal rhythm asystole, but they would say there's some organized activity there, and they would want that to be a fibrillation. This one's a giveaway. Don't look harder. And Todd, I'm going to come back to your thought. So you said you thought you saw a sawtooth, which is fine. If you don't have a QRS complex, though, it doesn't matter. There's no atrial. It goes right to, if there's no normal QRS complex, it goes into your ventricular pile, and there's no QRS that's noticeable. So you don't need to really, you can't put it in the atrial category because there's no QRS. So what about this one? It has no pulse with this rhythm. What is it? These are the worst because nothing calls you into the room. Don't even name it. They have no pulse with the rhythm. It's pulseless electrical activity. If they say there's no pulse with the rhythm, there's no pulse with the rhythm. It doesn't matter what it's called. It's called dead. So it's pulseless electrical activity. So if that is called out on any of your strips, patient has no pulse with this rhythm, you call it pulseless electrical activity, and the codes for, the treatment for it is code drugs and CPR and actually not defibrillation. So you're going to do CPR, bag mask, and do you shock them? You only shock ventricular rhythm, so no shock. And again, I'm not teaching you ACLS. This is the ACLS pretest. But if I do ever say patient has no pulse with this rhythm, it is telling you it is pulseless electrical activity. Just because you have electricity doesn't mean you have conduction. All right, this one's a little bit on the odd side. What do you think? Let's look at the rate. It's always good to collect yourself with a rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. All right. For me, I'd stop here. Greater than 150, that counts as SVT as far as I'm concerned, unless it's got a wide, weird QRS. Does it have a wide, weird QRS? Nope, it's got a normal narrow, it's one box. So it's either in the atrial category or it's a, I would probably call this for you, I'm telling anything greater than 150 an SVT. I'm not sure if they're going to want you to call this one a sinus tachycardia or not. Let's see what they ask. Let's see. We'll call it an SVT. Let's see. They might want to call it a sinus tachycardia because there is what I'm seeing here is possibly a P wave before every QRS, but I think I need to slow this down to find out if it's an A flutter. So I'm going to call it an SVT. Let's see. I might get this one wrong. Nope, they wanted to call it a sinus tachycardia. For me, I would call it an SVT because I'm not sure enough that those are normal P waves. So you could see there's a little range in interpretation there. They wanted to call it a sinus tachycardia, and I was glad we came across this one because they want that you to call this P waves. Now, me being a cardiac nurse, I would probably call it supraventricular tachycardia and rate control it to make sure that's not an A flutter underneath it. But that's because I'm a cardiac nurse. So, getting one of those wrong, that's not a big deal. I had a feeling that might be an issue. I will go ahead and anything over 170 or 150, I'm going to let you call that an SVT. Because it is 170 and they think you can see P waves, they want to have you call it a sinus tachycardia. But again, you could be wrong on that. I could be wrong, and that could be a 2-to-1 A flutter, or that could be a 5-to-1 A flutter, and when we slow it down, we see it. So I would want to treat it because I would treat a sinus tachycardia differently than I would treat an atrial fibrillation. But either way, probably the intervention that you're going to get on this one is going to be a rate control med, rather than, oh my God, we got to treat this SVT. We're not going to give adenosine to this. We're going to go look at our patient. This patient is probably okay. They're probably talking to you. They're probably asymptomatic, and we would probably give some metoprolol or cardizem or something to slow the rate down, and then we can take a look at that P interval a little more to diagnose it. So again, I would not make you choose between SVT and tachycardia on the test. For me, I would be happy with either one of those answers. Let's see what else. Are you guys good? Do you want to keep going through it? I know it's after 2, so okay. I'm happy. I'm still recording it, so let's go to next question. All right. Getting a little on the tricky side here. So let's do a rate. 1, 2, 3, 4, 5. Oh, I know where we're throwing this one. It's going in the Brady. So look, you guys are already doing Mobits. You're like heading in there. So what we need to do is, one, I'm looking too at this QRS to see, is it normal or narrow? And it really does. It is only 2 boxes, so it still fits within normal narrow, even though it looked a little wide to me. Let's do our PR intervals. So let's take this one. We're starting it here and going to here, mid box. So we got 1, 2, 3, 4, 5. So I've got about 5.5 boxes there. This one starts here and goes to here. Ooh, 1, 2, 3, 4, 5, 6, 7, 8 boxes. This next one starts here and goes to here, and we're at 1, 2, 3, 4, 7, 8, 9, 10 boxes. Oh, I'm starting to see a pattern. And then we've got here to, a drop. So what are you thinking? Longer than you drop? Now you have a winky bach. It's longer than you drop. Did we get that one? Because there's a couple of type 2s in there. If the PR intervals had been exactly the same, so this one was a little bit shorter, so this one was sitting right around 5, and then we get a little bit longer, and then we get a little bit longer, and then we have a drop. So longer than you drop. So it is a type 1. Yay. Ideas? Let me stop it. Well, that looks like textbook. Torsades. And they don't give you torsades here. It's called polymorphic or multiple size VTAC. Monomorphic is exactly the same amplitude. Polymorphic is multiple amplitudes. Good job. Our rate is 60. So we want to throw it into the Brady block. And so this is the thing, is the nice thing about having those areas. Like I threw it into the Brady block. I don't need to name it. I know what the treatment is. I threw it in there. It's going to get atropine. It's going to get dopamine, or it's going to get a pacemaker. We know what's going to happen to it. We don't need to name it. But if you want to name it, let's name it. So P before every QRS. Yep. Dropped. Yep. So I'm thinking we got something going on here, but let's do our PR intervals. Let's check here to here. 1, 2, 3, 4. And again, this is why you don't need to spend your time on this on the test. I'm not going to test this. 1, 2, 3, 4. One, 2, 3, 4. That one's 5. This one's missing. This one's missing. It's hard to tell where this piece starts. 1, 2, 3, 4, 5. 1, 2, 3, 4. This is 5. So they're basically exactly the same, except you have dropouts. So remember, 1st degree and 3rd degree have no dropped QRSs. Okay, so as soon as you have a dropped QRS, you've ruled out 1 and 3. Okay, so 1 and 3, no drop to QRSs. So all we know is that it's a Mobitz of some kind because we have dropped QRSs. You have to decide, is your PR interval longer than you drop, or are they about the same? And really, one small box, that's kind of an interpretation thing. We're going to call this about the same, and we're going to call it a type 2. And we are right. Woohoo! Look at that. We're training you in. You're going to be telling nurses before you think about it. Is anybody here a monitor tech? You probably signed off if you're a monitor tech. You're like, no, I got this. All right, what do you think? Crickets. All right, I've got a poly VTAC. Anyone else? A flutter. Todd, you just want everything to be atrial. Is there a normal narrow QRS in there? If there's no normal narrow QRS in there, there's none of these are normal or narrow. I would throw it, it's not in the atrial column anymore. Okay, we got to get rid of the atrial thing, because remember, there is a 1 to 3 small boxes QRS with every atrial rhythm. So we can't call it atrial because these are a mess. It's either VFib or, no, it's not SVT because that's got a normal narrow rhythm too. So atrial fibrillation, atrial flutter, and SVT all have a normal narrow QRS. These have wide QRSs. There's nothing normal or narrow about any of these. They're all wide. So it's either a VTAC, which is regular, or it's a VFib, which is irregular. So do you think these are regular or irregular ventricular beats? They are irregular ventricular beats. Like if they all looked like these here, if they all looked like this, then we could probably call it a VTAC. If it all looked like this, we could call it a VTAC. But we've got these little guys going in here. We've got all these random things. We're going to call this a VFib. And it doesn't really matter because when we go in and look at this patient is dead. So we're coding them anyway. And it doesn't matter. You're going to go in and check a pulse on this patient, whether it's VTAC or VFib. And when you go in and check a pulse, it's gone. And so it's VFib. And the only reason, this is coarse VFib because, and I have a hard time between the two of these because, you know, but they want to put forth the knowledge that VTAC looks regular. It's just wide. This is not regular. There's little, there's big, there's small, there's organized, there's disorganized. It's everywhere. So it is VFib. Next one. Well, that's a sick heart. We've got a rate of 60. So we know what we're going to do to treat it. Sometimes we don't even bother naming it until if we are symptomatic with a 60, we might try atropine on this one. But let's name it. So we know it's Brady. Let's look at its P waves. P before every QRS. There's a P. It's kind of flat. There's P. That's a nice one. There's P. That's a nice one. I think that's a P. Yep, that's a P. Nice one. That's P. Nice one. So do we have any dropped beats? Are those regular? It's either a first or a third because it's regular with no drop beats. So we can get rid of the type 2s so we don't have any drop beats. So we look at the PR interval and we look at, let's do this one goes from here to here. I think Todd got it. 1, 2, 3. We'll call that one a 4. This one goes from here to here. 1, 2, 3, 4, 5, 6. That's a 6. This one's about a 6. This one starts halfway through there and goes all the way to here. Holy moly. God, that's like 8. So basically what we're seeing is that we've got a 4, a 6, a 6, 8. So it would be a type 1 if we had a dropout, but we're not having any dropouts here. So we're either a first or a third. A first would have a consistently long PR. So I'm super suspicious that this is a third. We do our double check to see if this is a third. And what we do is we check, is this regular? And you would see if you measured these. Yes, that's pretty regular. And then we check our P to P intervals the same. So now we start looking at anything that's suspiciously a P. And we see that we could march this out. That these P's are completely disassociated. Those are all P waves. And we know that we either have to call it a first or a third because there's no drop beats. And this one wins third. And if you guys can tell this, you're already amazing cardiac nurses. And you're right, this is a 3rd degree AV block. And you are correct. Look at you guys, you're amazing. You're already passing ACLS. You don't even need to name it to know which algorithm to go to. We gave you Brady's, atrials, ventriculars. What do we want to do with this one? 1, 2, 3, 4, 5, 6, 7, 8. This is 80. Here's our rate. P's before every QRS. There's one. There's one. There's one. I think there's one. There's one. There's one. There's one. There's one. We got, looks like P's before every QRS. Let's look at our rates. We've got 1, 2, 3, 4, 5, 6, 7, 8. One, 2, 3, 4, 5, 6, 7. But we just said if we don't have any dropped beats, it's either a first or a third, right? 1, 2, 3, 4, 5, 6. 6.5. So does it fit the, let's see. One, 2, 3, 4, 5, 6, 7, 8. So we're kind of all got some prolonged beats here. One, 2, 3, 4, 5, 6. So they're not even. So I'm not tempted to call it a 1st degree block, because they're pretty even. Or, I mean, they're not that even. They go from 6 to 8. This one's tricky even for me. Are these QT intervals? Let me get my little calipers here. So what we're going to look, oops, let me blow this one up. The only reason I'm not voting for 3rd degree on this one is because this one looks like this is the whole, half a diameter of that circle. This one's half a diameter of that circle. This one's longer, so it's not really regular. This one's half a diameter of that circle. This one's a little longer. So it's not really regular at this point. I think I will probably call this a 1st degree along with you, and then we'll see what we've got going on. But you're right, it's not really a fibrillation. It's definitely, it's not a Brady. I'm wondering if they want to call that PACs. Let's call this 1st degree and see what you guys got. This one's tricking me out too. But 1st degree is not on here. It doesn't want to call it 1st degree. Let me do another check. Let me look P to P. I think this one might, I'm going to make a wild stab here. 2nd degree type 2. I missed that one. There was no drop. That's why it messed me up. Yeah, so they wanted to call this one a 2nd degree type 2 because it was dropping randomly. But unfortunately, I don't really see where the drop is unless this is the, unless this right here is considered the drop. So I think this is what they're looking at, this one. So this one tripped me up too. Do you see how I'm lining up the R with the mid-axis here? And basically the next R is supposed to start at the end of that circle. And this R starts at the end of that circle. And then they're calling this a drop. That should be where it drops off. And then this one goes to things. So basically it's having very quick drops. This one is a very tricky one, and I do not feel bad if you don't get that, because it's basically dropping every other beat. But I'd have to get a longer strip to clarify that, because it's not regular enough here. They're saying this is the regular rhythm there, that's the regular R to R, and all these other ones are drops. And yes, that does make it a Mobitz type 2 if you're doing that, but that's a very tricky rhythm. Lord have mercy. I even got that one wrong. And if the 20-some-year cardiac nurse is getting it wrong, you need a cardiologist to see that. No, that would be type 1. They wanted to call that one a type 2, that previous one. They wanted to call that a type 2, which means the PR interval did not lengthen before the QRS was dropped. With that one, it was too hard to see. There was no pattern. I mean, it was dropping every other beat. So I'm just going to call that one, that was a tricky stinker one. I was probably getting too many right, and they threw a hard one at me. And I would never make anybody feel bad about not getting that. That's a tricky one. This one, though, not tricky. What do we got going on? That is just a sinus Brady. Everything looks right except your rate is 50. So we can call that one a sinus Brady. But you have a normal narrow QRS, and your PR interval is perfectly the same. It's 3 to 5 small boxes. Looks good. What do you want to call that one? That is definitely a V tach, because it's exactly the same. So Lauren, fibrillation is unorganized completely. So there's no rhyme or reason to it. This one looks exactly the same. It's marching out beautifully like little soldiers. They're just wide, weird soldiers. So we can call this one ventricular tachycardia because it's ventricle, because look how big and wide it is. It's wider than 1 to 3 boxes, and it is regular. So we're going to call it tachycardia, but which one, monomorphic or polymorphic? Definitely monomorphic. It's all the same amplitude, so monomorphic. We're getting there. Oh, that's a beauty. What do you think? P wave before every QRS? That's the sawtooth one. It sure is. That's a 3-to-1 flutter. What that is showing you is that, not fibrillation, flutter. Each one of these, they are all P waves. They are fluttery P waves. But what this is yes, there are P's before every QRS, but there's 3 of them. There's 3 P's before every QRS, and it looks like that sawtooth pattern. It is atrial flutter. Good job. And this is barely on the realm. This is about 2 to 3. This is getting to be a little bit on the wide side, but that's a pretty sick heart, because the atrium is fluttering and the ventricle's having a hard time conducting around itself. That's why this is getting longer. But yes, you're right. That's the sawtooth one. And then I think they have you finishing out with a very tricky one. So P before every QRS. Well, it's definitely tacky. I approve. That is definitely a tacky rhythm. Let's get our rate on this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So our rate is 170. we have a nice PQRS here. We've got a nice PQRS here. Then it kind of starts merging together, and it's getting faster. So, and then it kind of merges into 1. So you can see how there's like that nice T. You got to have a nice slow rhythm to really read it. And yeah, I think I'm going to feel pretty safe in calling this SVT. They like to trick you a little bit. And, you know, before the 170 was sinus tach. But I'm going to tell you the reason this one's SVT is because you can see it speeding up. You can see how there's a T, and then a P, and then a T, and then a P, and then it starts merging together. And now it's merged into we don't even know. They want you to see that this is developing an SVT. And you did it. Look at you. You don't have to go through all the rest of it, but like I said, there's that. And then there is EKG Ninja, which does very much the same thing. Not this one. Not the rules. Shoot, where is it? I'll find it and I'll put it on there. There's one where you can see the rhythms. There's a couple of them. I'll put the links in there. And, oh, it's practical clinical skills, EKG. This one has good rhythms, too. But, again, don't freak yourself out about blocks. If you miss them, it's perfectly fine. But here you have the same sort of thing, and they let you have calipers so that you can measure out. And this is actually a really nice one because you can measure out your intervals here, and it gives you the reading down here. So I will put this link and the ACLS pretest in your modules so you can practice with these. But you can go ahead and figure out what you want to call it. Check your thing, and it will give you, and that's not normal sinus rhythm, that's wrong. But it'll tell you what you've got. So anyway, I like those. Practice those, and have fun. And we will do heart failure next week. I'm going to stop that one.